My talk today is going to be a little different from what is normally presented during this time. Today, I'm going to provide a little insight into the racial inequality of maternal morbidity and mortality and make some suggestions on how we can work to combat these injustices. Rates of maternal complications and death have been declining for many years in other industrialized nations. However, here in the US, that rate has been rising. The maternal mortality rate in the US was 26.4 deaths per 100,000 live births in 2015, which is the highest of any resource-rich country. Non-Hispanic Black women experience maternal complications at an average of 3 to 4 times and up to 12 times higher in some cities than non-Hispanic white women, even after controlling for socioeconomic status. And nearly 60% of these deaths are preventable. Most of the deaths were related to clinician, facility, and system factors, such as inadequate training, missed or delayed diagnosis of complications, delayed or ineffective response to obstetric emergencies, and most importantly, poor communication between communication and coordination between clinicians. Some of the contributing factors to the disparities faced by Black women leading to the disproportionate adverse maternal outcomes are racism, discrimination, chronic stress, how maternal mortality is collected and analyzed, and the quality of hospitals the mothers are giving birth in. There is no easy answer to how to fix these disparities, and a host of factors need to be analyzed and addressed. I envision a few important interventions that can be put in place now and moving forward. And as future health practitioners, there are a few things that we must all do to help reduce these disparities. And the first and probably most important is pushing to implement required anti-racism training beginning in medical school and continuing throughout health practitioners' careers. And on top of that training, first and foremost, we must believe Black women. Believe them when they feel that they're in pain because this could be labor. Believe them when they feel that they can't breathe, as this could be a blood clot that is embolized, and believe them when they feel off, as this could be the development of preeclampsia without the typical clinical signs that we're familiar with. And we need to believe the data that's in front of us and not shrug it off, as many of the high levels of Black maternal death are preventable. We need to stop teaching and training our colleagues that race is a risk factor and start looking at the real culprit, racism. We need to train our health practitioners about the concept of weathering and how from chronic stress due to racism and other factors can affect Black women's allostatic load, which can lead to these increased complications during pregnancy. Now, allostatic load is the physiological burden imposed by stress as indicated by 2 categories of biomarkers: the primary mediators, which comprise of the substances the body releases in response to stress, such as cortisol and epinephrine, and the second being the effects from those primary mediators, such as high blood pressure and metabolic syndrome. An allostatic load algorithm was specifically designed to study this concept of weathering. And the weathering hypothesis, which was first introduced by Dr. Arlene Geronimus from the University of Michigan, suggests that Black people experience early health deterioration as a consequence of the cumulative impact of repeated experience with social or economic adversity, racism, discrimination, and political marginalization. Dr. Geronimus reviewed this theory in regard to allostatic load in 2006 and found that Black women had the highest probability of high allostatic load scores regardless of socioeconomic status, and the highest score compared with their male or white counterparts. This is thought to be due to the double burden of discrimination Black women face for being more than one socially marginalized group. Second, we need to work together to establish more maternal mortality review committees and require them in all hospitals. These committees help standardize how maternal deaths are classified and accounted for throughout different states. Third, we need to work to improve quality of the hospitals women are giving birth in. Quality improvement, or QI science, has been around for years, and they help to improve healthcare quality and outcomes such as reducing nosocomial infections and providing early elective deliveries. Now, in 2006, the California Maternal Quality Care Collaborative, with the state public health department and many other partners, launched a statewide QI initiative to improve the quality and safety of maternal care in hospitals throughout California. Now, through this initiative, overall maternal mortality in California decreased 57% from 2006 and between 2006 to 2013, and which is also the lowest rate in the country in the US. And maternal mortality among Black women also decreased 50% in that time frame. Now, as a country, we're moving in the right direction to implement changes. However, there is still a long way to go. And as citizens and future physicians, we need to continue to advocate and fight to end these health disparities. We need to eliminate the racial disparity gap of maternal morbidity and mortality in the US by mandating anti-racism and diversity training, holding each other accountable, creating more maternal mortality review committees, addressing hospital quality, and most importantly, we need to believe Black women. I envision a world where all women have the rights, respect, and resources to thrive before, during, and after pregnancy, regardless of race, ethnicity, or socioeconomic status, and I hope you do too. Thank you.